Welcome to the Critical Care Obstetrics Podcast. I'm Suzanne McMurtry Baird, the Nursing Director for Clinical Concepts, and I'm joined today with my partner, Dr. Stephanie Martin, our maternal fetal medicine expert and maternal medical director, I can't even talk today, at Clinical Concepts. And we are thrilled to have a guest on the podcast today, Jen Hamilton. And we're going to get to a little bit about you in just a second, but we're thrilled that you're here and welcome on the
Thank you
podcast.
so much for having me. I thought it was an honor whenever you guys came across my email. I was like, absolutely.
It's our turn to fangirl this time.
Yeah, we get to fangirl. Yeah, so we're excited. But for those of you who have not met Jen or been on her social media or soon to be reading her book, Jen is an OB nurse who used to be an ED nurse. She's an educator. She's an advocate. And she's known for being very candid, honest, and still caring for patients at the bedside. She's very staff and patient centered. So, and so we thought it would be really interesting to talk to Jen today about how she, her experiences in the emergency department and if she ever took care of any OB patients there. And then now as an OB nurse, what it's like if she has called to the ED to care for an OB patient in the ED. So, but I also wanted to mention that you are soon to be, or you really are, an author, but your book is going to be released in May and it's called Birth Vibes. So tell us a little bit about your book before we get started.
I think that all of us, including people who are listening, can understand that, especially in recent history, birth plans have been the thing that kind of guide patient care. And I would experience either watching videos from people who were retelling their birth stories or from patients coming into the hospital that there were some people with very, very specific birth plans, and they kind of hung how their experience would be based on how closely they followed that birth plan. And I would see people online retelling birth stories that, in our minds, as we're watching it, we're hearing a story of a very normal, birth experience. But because there wasn't, compassionate, empathetic, timely, accurate communication, it imprinted on them as super traumatic. And I thought, like, what would it look like if we could build a birth plan around the things that don't change, right? So your support people and what they're doing for you. What kind of environment do you need in order to feel supported and heard? What kind of questions do you need to ask in order to make really confident decisions? Because you can have a birth that goes completely to plan, checks off every single box on your birth plan, and still leave that experience feeling unheard, disrespected, unavailable to your providers as far as like the communication part. And so I also know that you can have a birth that goes wild, goes not even anything like you wanted it to, but still can have a positive experience at the end where you knew that you were able to make decisions that you felt confident about. You were involved in your care. The people around you knew that they had your back. And so I wrote a book around the stories that we see as providers of births that go different, but still are transformative, impactful experiences. So the first half are all HIPAA compliant stories of things that have really happened in real life, but I kind of had to mesh them with other patients in order to keep the anonymity there. And then the second half is all the information that we wish that patients had whenever they come in to have their baby. Because everyone here knows that sometimes you even have patients who come in, and I'm not trying to be funny, but you're having to explain that, they have 3 openings down there. And having to explain the logistics of how things work. I had a patient yesterday that I was explaining, how we were going to ripen her cervix. And the first question I asked her was, do you know what a cervix is? And she had no idea. So that I get out the whiteboard, and try.
And they're afraid to admit that or even ask to explain because they feel like they should know.
Exactly. And they'll nod along like they understand what you're saying. And so we have to meet patients where they are. And so that all the back half is just like the basics, the information that I hope that everyone could come into the hospital understanding, so that they're able to make better decisions for themselves that they feel really good about. Um,
I
and I've
think you
already
said
had
that.
some.
I'm sorry to interrupt,
Yeah.
but I think that the way you said that was really impactful because, when we hear the word birth plan, it can strike fear in a lot of providers because it's almost like everybody in the room is trying to compete for control, which is not
Right.
okay.
Right.
Because what matters really is the patient and then that we get the best outcome, right? This is her experience. It's her birth, and we sometimes forget that. But I just saw recently a post on Facebook where a practice had essentially posted, not essential, they posted that we do not allow birth plans in our practice, and if you don't like it, you can go find another practice. I mean, we have
It's
lost the
insane.
plot if we can't listen to what our patients
Yeah.
want. So the way you're expressing it, this reframing of what I'm hearing is almost like, let's understand what your expectations are and what you want things to feel like and go like. And then we can take all the medical components of it and say, well, what about this medical component? And what
Yeah.
about this medical component?
Yeah. And I use the example, for instance, you can have someone who puts on their birth plan intermittent monitoring, which for low risk people is perfectly
Totally
valid.
okay. Hmm.
And, if you come into the hospital, and let's say that you come into the hospital with decreased fetal movement. Well, that might be a conversation where we look at the birth plan and we take the new information that we have and kind of adjust things. But one of the most important parts of a birth plan is understanding, for me as who's taking care of you, understanding the why.
Hmm.
If I can
Yeah.
understand why intermittent monitoring is important to you, that is so helpful because I can
Hmm.
help protect those values even if
Hmm.
things change.
Hmm.
So if you tell me, "Well, I wanted intermittent monitoring because I didn't want to be tied to a bed." Honey, we
Yes.
got that. I
Yeah.
got you. We're going to move around as much as you want to. Um, and being able to know how I can best protect that value, even if things go different, helps you to have a better experience because we're not trying to take that part of what you're wanting away from you. It's just like having the new information can help us make really safe decisions and really confident decisions and adapting with new information rather than being averse to it. There's one story in the book about and I don't know if you've had experience in caring for patients who have this mindset, but it was a patient who um, she was having a positive pregnancy, meaning that she would not listen to any
Hmm.
negative birth stories, which valid
Hmm.
because that can
Hmm.
give you lots of anxiety.
Hmm.
But she wasn't going to listen to anyone who said anything about her birth plan negative. She just cut it off completely.
Hmm.
Well, in the course of labor, things were going differently than she wanted. In this particular story, she had been ruptured for several days and was getting choreo and all the things. Um, and we had the conversation about, you know, whether we use the new information to help us guide decisions or whether we shut it out completely and then, can deal with the repercussions that can follow. But
Hmm.
part of informed consent is knowing, yes, the risks and benefits of accepting intervention, but also the risks and benefits of declining intervention. Because I say also that you can decline yourself all the way to an emergency C-section. And it's using the tools that we have
Hmm.
carefully and judiciously and not taking a toolbox and throwing every single tool in it at somebody if they don't need it. That's when we can cause some issues. But, those tools exist for patients where things are going different. And how do we use that new information about our current situation to be able to pick carefully from that
Hmm.
toolbox in order to have the best outcome?
Comes to mind immediately a patient that I took care of years ago who, in the area I was practicing at the time, there was a large population where culturally it was not acceptable to say, like what you're describing, to say negative things because that would essentially bring them to truth.
Right. Yeah. Yeah.
Okay. And unfortunately, this patient had a cardiac abnormality that's one of the most severe ones you can have in pregnancy was Eisenmenger syndrome, and she did
Yeah.
end up passing away within the year postpartum, unfortunately. But this diagnosis came to light while she was pregnant. And so I'm having to counsel this patient about the seriousness of this diagnosis without saying this will happen.
Right.
knowing what will happen. But I
Mhm.
can't say that because I have to preserve this relationship. I want to make sure she feels comfortable seeking care because there's a reason we haven't diagnosed this up till now. She's not been comfortable coming in for care because people weren't respecting what she had to say. And that was a quick learning lesson for me as a
Yeah.
young physician. Like, okay, this is about meeting her where she's at and giving her
Mhm.
what she needs. And somehow we were able to bridge that. I'm sure I made some missteps along the way, but well, I'm personally am excited to pre-order and read your book.
Well, thank
And
you.
you guys listening need to pre-order this book because that pre-orders are important. Jen won't say it, but I will.
They are. You're right. They are very
Pre-orders are
important.
hugely, hugely important. So don't wait till it's out. Pre-order your book. Bring it to A1 in June.
I know. If I bring mine in June, will you sign it?
100%. There will be a book signing for sure.
Okay, I know that's important. I did a book signing for A1 last year, and I was like, "What do I put?"
Did you
That was the
practice a
biggest.
signature?
Yeah. Do you
Yeah, my
practice your
signature
signature?
looks like a J, blah, 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 H. I need to get better at that.
Oh, yeah,
Well, I
that's
want to
fun.
hear about going from the ED to OB.
Whew.
I mean,
Really?
Yeah.
I,
Oh, yeah.
it's got to be quite an experience. I mean, two of the most. I mean, there's a reason that all the TV shows are about the ED, right? Because chaos happens down there, and trauma happens down there, both
Yeah.
physically and metaphorically. So, like, do you feel like your ED background prepared you well for what to expect in labor and delivery?
I am so grateful for my ED experience because, and I'm not saying that there's that going straight into labor and delivery, you're not an amazing nurse. That's not what I'm saying. Me having an ED background, I'm able to not just see pregnancy,
Mm,
not just see complications of pregnancy, but
mhm.
there's always this part in the back of my mind of thinking about things that are not pregnancy related and how I would manage those things. And so I'm so grateful for, like when I'm in those emergency situations, you got somebody who comes in with a PE, with a non preeclampsia related epileptic seizure, like
Mhm.
those kinds of things. I feel more confident than I feel like I would have been without having that experience. So when I was in nursing school, I had decided pretty quickly that I didn't want to do labor and delivery
Interesting.
because my experience was very wet. Okay. So I was like,
Literally.
this is
Literally?
a
Yeah.
wet place to work. And I was still kind of like squeamish back then.
Yeah.
I was the kind of
So
girl who
funny.
needed to watch YouTube videos of people getting their blood drawn in order to feel confident that I wouldn't pass out.
Wow.
There's a moment that I was in clinical one time and I was drawing blood from a central line and I was like, "Uh-oh, this feels very warm in my hand. This is really red." Like I started really thinking about it. I ended up laying down in the bed with this patient so that I didn't pass out.
Fainted
So,
in OB, in the OR,
yeah,
in labor and delivery.
yeah,
When I was a nursing student, I was standing by the suction machine and I heard all
yeah,
the, coming
yeah,
into the suction machine. And I just went down on my hands and knees and crawled out of the OR.
yeah. And
Yeah,
it'll
I was
hit you
out.
fast too. But I saw an epidural and that freaked me out and
Mm.
I don't know. I just kind of didn't I didn't feel confident that I could do it, like stay vertical. Because I passed out getting my ears pierced, flu shot, blood
Yeah,
drawn,
me too.
TB test, IUD. I'm a fainting goat.
You
So I
have
was
a
like, no.
very, very intact vagal nerve.
Yeah, that's right. She
Yeah.
does big work. um, so yeah, and ironically, I ended up going to the ED where there's all sorts of blood and guts, which
Yeah.
is a whole nother thing. But
Some weird
yeah,
stuff down there.
I
You
did
know, when
6
I was
years in
in
the ER before.
6 in the ED?
Yeah,
Okay. When I was in med school, I thought about ED. That was my first choice before OB because I love the chaos and the emergencies and all that
yeah.
stuff. And I didn't do it because when I went to the ED, I'm like, oh, this is family practice, but no continuity.
You
Like
are
I didn't even get the
100%
benefit of the
right.
patient relationship. Because it's not what you see on TV a lot of the times. It's upper respiratory infections and bladder infections and a little cut and whatnot. And so I was like, let's go see where else. And OB was so much more
Yeah.
chaotic. I loved it.
I dare say that like 90, that might be exaggerating. I was going to say that like 90% of things that end up in the ER
Mhm.
could be managed
Yes.
elsewhere, whether that's
Yes.
urgent care or their, PCP.
Mhm.
Mhm.
But yeah, and then it's that 10% that kind of keeps you going as an ER person who's like,
Uh-huh.
thrives on that adrenaline.
Yeah.
I've always said if I didn't work OB, I'd work in the ED.
It's
Same
fun.
personality type, I think,
Yeah, yeah, yeah. There's
Mhm.
a lot of similarities, a lot of crossover.
Yeah, yeah.
Unpredictability. You have to
Yeah.
be able to critically think. You have to be able to deal with the unpredictability.
Mhm.
Mhm.
You've got a variety. You're going to see. You never know what's going to happen. You
Right.
just never know what's going to happen
Yeah,
in
just like I
any
said,
given shift.
just like OB,
Mm-hmm.
Yeah.
Mm-hmm.
right?
So, do you remember your first OB patient in the ED or one of the first?
Remember feeling anaphylactically allergic to someone who was pregnant. Okay. They come in, I say, "Why are you here? What is," even if they came in for something non-OB related, like, "My knee hurts. Where's the baby?" Like,
Yeah.
I didn't
Mhm.
like having a patient that I couldn't talk to, that I couldn't assess really, because they taught us how to put somebody on the monitor,
Mhm.
but
Interesting.
I don't know anything about that. Where I work, so, like, in the
Mhm.
system where I work, we have something called an OB rapid response nurse. Have you ever heard of
Fantastic.
that?
Yes.
Yeah, so
Love that.
what we would have is, like, if someone comes to one of the hospitals in the system that doesn't have labor and delivery there, we can I say we now, like, we as rapid response nurses can, remotely assess. They put them on the monitor, and we pull them up on Obix, like, we can see
So
their
smart.
strip, which is lovely. You have a 36-weeker coming in for, decreased fetal movement, and you pull them up, and you got a category 1 right. I mean, that's such a reassuring feeling to know
Mhm.
since you can't physically be there.
Mhm.
Um, so that's lovely. So we had such good resources for OB that I was able to exist in the ER without ever having to get real comfortable with it,
Mm.
because I was able to call OB Rapid Response or, kind of pass it off. So
Mhm.
I never wanted to take anyone who was pregnant. And during my 6 years there, I was pregnant twice, and so I had my own pregnancy stuff. And so I was like, I don't wanna see anything bad. I was scared of seeing anything bad.
I think that's an important lesson though, because, just you knew what your resources were.
Yeah.
You knew your limitations
Yeah.
and you knew your resources and you had support. So, not everybody has to know everything in every situation. You have to know how to get the right people at the bedside at the right time.
Right. And in the ER, just by nature, you know a little bit about a lot,
Mhm.
and so what I knew about OB was the phone number to the rapid response nurse.
Well, see,
That's what
that's
I knew.
important, though. I mean,
Yeah.
I think that's that again. I mean, that's so key. But let's set kind of a clinical scenario
Okay.
stage so that people can understand kind of what some of the issues that we see are in an adult ED. So let's say you had a 28-year-old Gravida 2, Para 1 at 32 weeks gestation. She's pregnant.
Mhm.
ED people love that, like you said. And she comes into a community ED with shortness of breath, chest pain, blood pressure is 142 over 87, heart rate's 112, and her respiratory rate's 24. I see that from an ED perspective, or what I would anticipate. Chest pain in anybody is declared what in an ED versus an OB triage?
I mean, automatically you're gonna get an EKG because ED is thinking like, "Oh, your heart," but that's not what I'm thinking in this scenario.
Mhm.
Right.
And by the way, listener, we did not give Jen this case. She's
Yeah.
been
No,
put
this is
on
the
the
first time I'm
spot.
hearing it. Yeah.
It's on the spot,
Yeah.
right?
Uh,
So one of the big things is that A1 partnered with the Emergency Nurses Association. I don't know if you know this, to write a position statement, and I
I
helped
didn't know
lead that.
this.
Yeah, I helped lead that team to write that joint position statement on how OB patients should be cared for in the OB in an adult ED, which was a great collaboration. It was during COVID, so everybody was sitting at home like, "What are we going to do?" And it came to the door that we need to do this because there's so many um, patients that kind of cross each other's paths, and a lot of questions about what is the best patient to stay in the adult ED, or which one should pop off to OB triage. But then also with the new additions of OBEDs,
Hmm.
which patients should go there as well.
Yeah, we
So
deal with that a lot as far as like
yeah,
that the line in the sand of like this person needs to go here and this person needs to go there, you
I
know.
know. And sometimes the patient ends up being like a ping pong ball in between the two. So the moral of the story on that document was get OB involved. And before we kind of joined partners with them to write that, it was mainly about patients who experience a loss in the ED.
Oh
And
yeah.
that was it, which can also be a big issue for OB and teams as well as ED teams. And I feel like that, and from my perspective and hearing from the ED nurses, they didn't feel confident with that, or didn't have the resources that we might have for those patients experiencing a loss in the
Right.
emergency room.
Mhm.
So,
When I
so
was
that's
in when I was in nursing school, I did a really large clinical rotation in the ED, and I remember one patient that was like, I don't know, I want to say like 10 weeks or something, who was experiencing symptoms of a miscarriage. And one thing that was wild to me was I thought as a nursing student that, you know, if somebody is coming to the ED and like this, you know, they're bleeding or like there's something that looks imminent, that we gotta fix it, you know? And, you know, it took me that day really to realize that like where the biggest gap is in the ER in that situation, because we truly cannot stop a miscarriage that is happening at 10 weeks. Like there's nothing that we can do to like keep the baby inside. You know, there's was meeting that patient where she is emotionally and
Yep.
supporting her that way, you know, as long as like we're not bleeding too much, all that stuff. Um, what I saw missing was exactly that piece of like how do you when you have 4 other patients, how do you
Mm,
support someone going through that? Because that patient kept saying like, "Why aren't y'all helping me? Why aren't y'all doing something?"
that's
And, you know, as
right.
a nursing student, I was like, "I don't know, why are they not helping you?" You know? And so I see that gap also because ER nurses don't have that time that they need to be able to help someone through a loss in the ED.
right.
Yeah,
And
I have that conversation with patients a
yeah,
lot,
Yeah.
about but it's, this is just one patient at a time. It's not gonna fix the problem. It needs to be a bigger conversation, but
hmm
helping them understand the role of the ED in
Mhm.
bleeding and pregnancy.
Yeah.
And I'll tell them, I'm like, "I don't want you to have to spend the night in an ED and a huge copay unless," and I give them very specific
Yeah.
criteria. The other point
Mhm.
I make to them is, "It's your blood, not your baby's blood."
Mhm. Very
Because
true.
they don't necessarily understand that, and women understand vaginal bleeding, and they know when it's too much and not and not
Right.
too much.
Yeah.
So helping them understand it's their blood and not their baby's blood, they know what they
Mhm.
can tolerate losing,
Yeah.
and it makes it a little easier for them to wait till the morning
Mhm.
sometimes and
Yeah.
not have to, because they want reassurance and they want it fixed, and nobody, we can reassure, we can hold your hand, but we can't
Yeah.
fix.
Right.
if going back to our patient with the chest pain, in the workup, because I would see that scenario of a patient with chest pain, like you said, working them up for a heart,
Yeah.
but also maybe a PE,
PE.
and that
Yeah. That's where my brain goes.
I know. And so what what comes to my mind as an OB nurse though is it's probably not either of those. And as you said, it's probably that's not what you're thinking, because with that could come anxiety too, because the patient is short of breath, and that makes anybody anxious, right? But it also could be related to hypoxemia. But what do you think, as a now an OB nurse, if you had to name something that could improve in the ED and adult ED, what staff may not know or not have available for them, what would be the best advice for somebody like an adult ED to take to heart now that you are an OB nurse?
I think it's a couple things. I think that we could absolutely improve access to care by partnering with like larger hospitals, partnering with community hospitals that maybe don't have that OB
Yeah.
staff, by implementing something like a remote rapid response nurse role, I think that that could be huge.
Yeah.
Because if you even just have someone who kind of like looking at a problem from a different perspective, sometimes you can look at
Right.
a problem forever and ever and ever, and you see it the same way. But you have somebody who comes in with a different perspective, they can offer different solutions for things. Kind of like thinking about that patient in a different way when you kind of combine the fact that they're pregnant with the medical emergency that they're coming in with. But I think also having, and this is something that we deal with some from time to time in our adult or even pediatric ED, and then having labor and delivery like access,
Yeah.
is that when there is loss, just like we were talking about, partnering with a labor and delivery, even if that loss is not fetal. We have so many, I don't want to say so many because it feels like a lot when you're going through it, but when we have like SIDS cases, or when you have like toddler, there's a lot of co-sleeping stuff that I've dealt with, but we partnered with our pediatric emergency department to create a like go box of all of the, because as labor and delivery people, we deal with a lot of like fetal loss, and so
Right.
we have different ways that we can care for those patients. But in the ED, there's less of that, and so I think partnering is huge. um and then knowing what your resources are, I think is going to be huge for any ER nurse.
Yeah. We see a lot of hospitals these days that have like algorithms as to how OB is activated into the care of the patient. Um, Whether that's based upon gestational age or based upon, usually that's based upon gestational age, but when you would call OB, and our advice has always been call OB early.
Yeah. Oh, yeah.
Get an OB provider involved in the care, and not just an OB nurse, because I mean, even though the OB nurse is going to be critical to the fetal monitoring component if the fetus is viable, um, getting a physician, an advanced practice nurse involved early, and then somebody who could possibly do surgery if needed. Let's say it was a trauma. We just did a podcast on minor trauma, but in major trauma, still, that is key as well. And I think it's thought of that. But what about fetal monitoring in the ED? Have you ever had to do that in the ED as a emergency room nurse, or as a, or like calling OB to come down to do fetal monitoring, or have you ever had to provide that as a OB nurse?
Yeah. So, both. Whenever I was an ER nurse, our responsibility would have been to immediately call OB Rapid Response if we had a patient that showed up with a complaint. And trust me, I was on that phone immediately. You even looked a little suspicious,
Yeah.
like, when was your last period?
Yeah.
um, so calling them immediately. And then what our responsibility was that we would put them on the monitor. So like they would come in and do in services on like the toco and the ultrasound and like how to, now listen, did I do it correctly? Probably not, but enough to where they could see some sort of strip. And then the hospital that I worked at, if they were over, they've changed things since I left, but back then, I think it was like if they were over 20 weeks, we would get called.
Yeah.
We as in OB Rapid Response.
Yeah.
And so then they would come in. I was not responsible at all for interpreting any kind of fetal monitoring, nor
That's
should I
good.
ever have been. Like that. Don't trust me with that back then.
Yeah.
So, because when I walked onto the OB floor for the first time as like I'm shadowing here to possibly work here, I was like, why is no one concerned that every single one of these babies are in VFib? Like, y'all, everyone seems very chill. This is
Yeah.
bad, because that's not,
Yeah.
that looks like a bad strip to me.
Yeah.
A good
Yeah.
strip looks terrible to an
Yeah.
ER nurse. So I was never responsible for that. But now, as someone who does OB Rapid Response, I get called to go to all sorts of stuff. One time I was OB rapid response and got a call from, we have an OB ED where I work now.
Okay.
So the OB rapid response is responsible for 5 different hospitals. So if someone shows up to any of those hospitals, we always are able to remotely assess. We respond to 2 hospitals. So I got called to go down to the OB-ED. They're like, hey, this girl, has come in, and all I got was that her oxygen saturation is 50% on 15 liters non-rebreather. Now the ER nurse in me was
It's
like,
like, first of all,
no.
that's not right.
That's exactly my thought. I was like, there's no way.
There's no
Let
way.
me go help you put that pulse ox on.
Thank you.
Let me put it on better.
Or let's call the real RRT and get her intubated.
So I go down there, and the situation was that it was a patient with epilepsy who had been very, very strictly told by both her neurologist and her OB, don't you dare come off your Keppra, or like whatever she was on at home. And so, but she Googled that it's not good to take in pregnancy. And so she cold turkeyed it and had a status epilepticus 30-minute seizure where she
My word.
aspirated.
Oh.
Now, that was the craziest day as an OB nurse, because what ended up transpiring was we call it a code cesarean, but like a stat. She was like, I don't know, early 30 week, maybe like 32 weeks or something. Baby looked great on the monitor, but I was more about like, hey, this is bad.
What's happening with mom?
So, due to body habitus, she was a very difficult intubation. And I rode the bed with a Doppler, listening to what was happening while we're, code cesareaning her. And then they ended up putting her on ECMO. But
Wow.
because we had the resources that we did, because we had we call it the big house people. So we got the big, we got cardiology, we got pulmonology, we got the ECMO team, we got the main OR team, anesthesia, everybody is right there. Neonatology, because our hospital used to be a standalone, like our women's and children's stuff was all, well, it was
Don't
basically
get us started.
Yeah. all just
You're on an island.
Oh, yeah. So we never had that. So when we moved to this new hospital, we now had all those resources. And I just kept thinking, God, if we were back at that old place and we had to, wait an hour for like whatever it was going to take, I don't think she would have made it. So just having all of those teams that could come together for this one patient, she walked out of that hospital a couple weeks later with her baby. And I thought that was just incredible.
Yeah.
Because it was real, real scary. So now as an OB rapid response, I get to go to, toe pain or, that kind of stuff. So it's wild to be on both sides of it.
I think this is a really interesting perspective and a really important one, because last year, CMS made a requirement that every hospital be prepared to deal with obstetric emergencies in the ED, regardless of if you have obstetric services at your hospital or not. So this is not, there is no exempt hospital from having to deal with an emergency. So there's going to have to be partnerships. And I think telemedicine, the only good thing that that comes to mind from COVID is it opened up the doors for telemedicine in medicine, because it wasn't that we as providers were necessarily against it, but we weren't paid for it. You couldn't get paid for it, and therefore you couldn't do it because you can't, unfortunately, that's just the realities of practicing medicine these days. So COVID really opened those doors, and I think that's going to be the future for many of these places, helping to recognize and stabilize. You don't know what you don't know. That's true of those in the ED. It's true of those in OB. Suzanne, you made a point earlier, where if you're an ED nurse, you look at it this way. If you're an OB nurse, you look at it. I think of it like, if you're OB, you're more likely to look at it as everything's normal until proven abnormal. If you're coming from the ER, everything is abnormal until proven normal.
That is a really interesting mindset, but that's so right.
right? I mean, did you
Yeah.
have to shift? Did you make the shift, or have you always been abnormal first, then normal? Because that's a hard balance to
Yeah.
then have those low touch births when you're in your mind going, is everything normal?
Yeah.
Is it
It
really
was hard
normal?
for me to sit on my
Mhm.
hands in a normal labor. Do you know what I'm
Yeah,
saying? Like, that
yeah.
was very hard because and I tell people, OB is the only area of the hospital where we get excited when you're hurting. Like, we're like, "Yeah, girl, you hurt," because that means, progress and, like, that we're
Mhm.
doing something. But man, going from ER where where always the plan is, "How can I decrease your pain?" And then coming somewhere where sometimes people don't want that. A lot of times people don't want that intervention. And just having to be like, at first, "They're there," like, "Let me pet your head."
She'll
I don't know
figure
what
out
else
she
to
wants
do.
an epidural very soon,
Yeah.
but she doesn't want an epidural.
Yeah. So yeah, there's a lot of, and I know even in the outpatient setting prenatally, there's a lot of like, hey, this weird thing is happening to my body. That's normal. And it was very difficult for me to kind of figure out what is normal and what's not normal. Um, and when you come to like the anxiety portion of it with patients, having to, reassure people like what is normal or what is not, there would be lots of moments where I myself was having anxiety because I'm like, is this normal? Is this okay?
Yeah.
Or, even in like patients who come in with like I'm scared I'm gonna die. I'm like, shh, don't say that.
Say that word.
I know. Oh my
Because they
gosh.
try to, or if they
Oh
don't. If they don't,
yes.
they try to.
Yes. I've had so many patients come in for induction. I'm like asking about their birth plan. They're like, I don't want to die. I'm like, please don't say that word. Please. We're
Do
not
not
superstitious, but
manifest this. Yeah.
we're a little stitious.
Somebody knock on wood.
I know. Whew.
Yeah, we're a little
That's
stitious. That's
Yeah.
true.
oh, I definitely am when that comes up. But I'm also totally wackadoodle with, even low risk patients. I'm the type that's sitting there looking, what's going to happen.
Yeah.
I walked in one time to get an assignment and somebody said, you have the Bradley patient that is, back in the back. And I go, I get the Bradley patient, like me, Miss High Risk, nurse or whatever. And they were like, don't worry, she's got preeclampsia with severe features. I'm like, oh, phew. But that's my mindset. Like, what is going to happen to you? Because I'm like a magnet for that. But, yeah, that's a different mindset too, like you said, switching from ED into OB, but that's the reason why I always thought I would like ED,
Hmm.
because of that fast pace. But if you had to tell the ED one thing about OB and about the coworkers that you work with, and the people that you've worked with and learned from or what have you, if you had to give them one piece of advice about, your OB colleagues, like you should understand this, what would it be?
That we always want to help. Like, we love it most of the time when people ask for our advice or expertise. Like, we would love to weigh in on what's going on. I've had some situations where I was not called when I should have been because they said we didn't want to bother you. Girl, that's what I'm
Mm,
here for.
Hmm.
right.
So, I hope that everyone who's kind of doing this teamwork situation where ED is calling OB or vice versa, because we need y'all, like we need EED a lot of times as far as like,
Yeah.
when we get into the critical care stuff. And so when there is that really cohesive relationship of understanding that like we want to be there for you whenever you need us because we want you to be there for us when we need you.
Right.
I think that it works so much better when there's that teamwork like situation.
Did you ever experience situations on either side where you wanted the help and didn't get it? Because I can think back to times in my career when that wasn't like this, the willingness to help was
Right.
not always there,
Yeah.
and or there was just lack of ability, even if there was
Yeah.
willingness, like,
Yeah.
there's just not enough people to go down and do. Everybody's stretched, right?
Yeah.
So have you encountered that?
I think that whenever I did have that, it was one of those things where I'm thinking that something's wrong when it's really not. Because anytime I had a pregnant patient, I'm like, there something terrible is going to happen to everyone involved because they're in my care.
Hmm.
I was so scared. And so, I've got this patient that's, maybe on the monitor. I see them contracting every 5 minutes and they're talking to me through those contractions like you and I are talking. Me telling the rapid response nurse, like, she's contracting every 5 minutes. But they're able to see past that
Yes.
and be able to hear on the phone that this patient is able to talk to me in a calm manner. Usually that means we've got some time. So I needed them to be able to kind of talk me down. But in the moment, it feels dismissive. Like,
Mm,
can you not see what I'm seeing?
yes.
So it took that expertise on their end to be able to assess remotely that, even though we are contracted every 5 minutes, yeah, sure, she may be going into labor, but we're not imminent. Because I think that's what ER nurses are always going to feel like is like, oh, you're 6 weeks pregnant, you're about to birth. That's how it feels most of the time.
Yeah.
Yeah.
If you could, let's flip it
Yeah.
though. If you were from an ED perspective and you could tell OB something about an emergency department, one little tidbit, what would it be?
I would frame it more as like, instead of talking about the department itself,
Yeah.
um, there's two things that I'm thinking of. One is that, like, we're not stupid all the time. Like, we know a little bit about a lot, okay? So when we're calling you, we're freaking out most of the
That's
time.
so interesting. I've never thought of anyone in the ED as stupid ever.
Well, I think that we're afraid of how we come across whenever we're calling for something because we're freaking out,
Uh,
like
uh,
internally freaking
okay.
out. But then also when it comes to the patients, um, I think that knowing that non-pregnancy related emergencies still happen and to not always get siloed into thinking about, preeclampsia or, you know, whatever the next OB emergency is, because there's been other situations that I've been able to intervene in on my own unit where, one time I walked into a situation where someone was uh, not breathing awesome. And I'm looking at the work of breathing, right?
Mhm.
And, we've got a pulse ox on and it's in the 90s or whatever, but I'm noticing those subtle changes that are not
Mhm.
pregnancy related.
Mhm.
And, being able to, because that situation devolved very quickly. And so because I was able to say like, hey, this maybe is something else, she ended up getting on BiPAP and it devolved very quickly. I'll say that. But to be, the first person in the room to say, hey, something else, like my spidey senses are tingling.
Yes.
So um being able to
That's the abnormal until proven otherwise
exactly.
versus the normal because she normalized her
Exactly.
SATs, so it's normal now.
Yeah. So it was them thinking like, oh, she's anxious. And I'm like,
Yeah.
but what if she's not? But
What
what
if
Yeah.
if
she's
she's not?
anxious for a reason?
Yeah. Maybe she's feel and in that situation there was like a language barrier too, so it's kind of figuring out what she's
Mm.
feeling. But I think that I have heightened spidey senses on
Mhm.
non-pregnancy related emergencies because I've seen them in real life. So
Mhm.
I think that, for OB, remembering that those exist and that there's there's resources available, hopefully, where you work to help at least assess the situation. Maybe it's totally fine. Maybe that everything is awesome and it is normal, but having the resources to be able to say like, hey, can you come take a look at this? Because we not only so at my hospital, not only do we have OB rapid response, we have main
Mhm.
regular
Yeah.
schmegular rapid response too. And oh, my heart just soars whenever I see them walk in the room. And we've got, somebody on BiPAP or somebody that we're about to intubate or somebody that we're, might be getting ready to code, if we're like circling the drain on somebody who's really, really sick. Oh,
Mhm.
being able to have all those people in the room who deal with this on a daily basis. Shoo. Wow.
Well, and it's such a resource. It's a resource that a lot of times in OB we don't tap into it.
Yeah.
and we don't call the rapid response team in a timely manner, or we wait until they're in shock
Mm-hmm.
to call them. And then, because our patients, because of the physiologic changes in pregnancy, they adapt and tolerate a lot until they
Until,
don't.
yes, exactly. For sure.
Until they
Then
don't.
until they don't, they truck up that hill and then they go off the cliff pretty
Yeah.
quick
And it's
because they've been
trusting,
showing you, right, this
yeah.
decompensation.
And it's trusting yourself whenever you start to see those little changes. Like, yeah. It's because it's better to check it out fully and be wrong than to wait and wait and wait.
Yeah.
And then something happens.
Yeah.
Like the key you just said there was check it out fully.
Yeah.
Because all nurses, in my experience, I'm not a nurse, but in my experience, nurses have spidey sense. And a lot of times they shush it.
Yes.
Either
I never
because
shush
someone is
mine.
telling them that it's not real.
Yeah.
But the way you figure out it is real or not is to do an assessment.
Mm-hmm. Yep.
Like if a patient says, I feel like I'm going to die. Well, we're going to do a whole head to toe assessment here
Yeah.
and figure out if
Prove
you're
to me
right or
that
not.
you're not, actually.
Let's find out that.
Yeah.
Let me reassure you after I've made sure that everything's
Yes.
okay.
Prove it.
Reassure myself, and then I'll reassure you. Yeah.
Yeah.
Bingo. That's
Yeah.
exactly it. No, I mean, so if you had to go back and do it again, would you start an OB?
No, I wouldn't. I was talking to a nursing student yesterday, and she said, I want to do OB. Like, I want to be a midwife. Like, that's my goal. But I have an offer for my home unit, which was like a progressive care or something. And she said, I really think I might start out there, but I'm afraid that I won't be able to do OB. I said, baby, you will be so grateful
Yeah.
to have that background knowledge of basic, medical stuff that happen outside of pregnancy when you come to OB. It's such a good, and I'm not saying that people who only come to labor and delivery and have only been a labor and delivery nurse aren't incredible, amazing people, but I think that there is something to be said about being able to be comfortable in those weirder situations, and they don't happen all the time. But when they do, I'm like, I'm so glad that I have that knowledge. I'll tell you a funny story of when I was really glad that I had that experience. So we're going to time travel back to COVID. Okay. So we had
We're with
just moved from this standalone hospital that was just women's.
Mm-hmm.
I just became an OB nurse a couple years before, and it was COVID, and they were floating us everywhere because they needed help. And so we would get floated to other units to task. That was always the promise, is that we're there to task, start IVs, take
some
things to the
vital
lab.
signs.
Yeah, do some vital signs, take people in a wheelchair, discharge them, whatever. So I got sent to task in the ER. I was like, hell yeah, I know how to do that. That's easy peasy, just tasking in the ER. Wow. So I got down there and they said, what we want you to do is just help transport people. Now, keep in mind, I don't know this hospital very well because we just moved here. And we had only been there for a couple months whenever I got asked to go down there. I said, sure, no problem. And they said, hey, will you take this lady up to dialysis? I was like, if you give me some verbal instructions on where that is, sure. So all I knew about this lady was that she was a lady, and by context clues, her kidneys sucked. That's all I got. Because I'm just taking her,
Yeah.
I'm just point A.
You're not
point
in an
B.
RN role right now. You're just in transport
You're
role.
transport role.
Yeah. So I'm taking her up, and she was an older lady, so I just took her up in the bed. She's talking to me. I mean, just like me and you, just chatting. We're in the elevator, and she stops doing that.
No.
She stops talking to me like me and you. And I turn my head to look at her, and she's not with us right now.
No.
And so I'm like, shit. Like, what am I going to do? So I zoom out of the elevator. Keep in mind, I don't even know where I'm going, but I'm just going down the hallway till I can find something. I find dialysis, which is this closed unit. I'm badging in, beep, 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 let me in. And so I get her in there, and I'm yelling, help, help, help. This lady is respiratory arresting right now. And then the dialysis nurses look at me and say, she's too unstable to be here. Honey, we're past that right now.
I know that.
We're
Yeah.
past that.
Call a code, call a code.
Yeah.
She was too unstable to be in an elevator too.
Right. So she had stopped breathing completely. Her blood, like I'm hooking her up to all the stuff. And her blood pressure was like 270 over 150, something ridiculous.
Oh my gosh.
And I ended up like there's a like, you know, there's bags, like bag valve masks everywhere. So I grabbed the bag, I'm bagging her, and I'm like, someone please help me. No, I felt like I was in a dream, you know, where you're like, you can't run fast or like you can't, you know, you can't yell.
Yeah.
And a doctor walks by. I was like, do you need some help? Yes. Yes. So they ended up calling the code. The whole anesthesia team comes, they intubate her. Now they give her like a push meds for sedation, right? So they intubate her and they leave. Everybody's, because also I'm wearing OR scrubs. I'm wearing anesthesia, and I'm putting that in air quotes. I'm wearing the same outfit as them. Everyone there thinks that I am a CRNA because I'm wearing the outfit. Okay. So they leave her in my trusted hands of critical care knowledge. And I'm like, I am a labor and delivery nurse caring for this 88-year-old lady who is intubated right now.
Doing a favor I'll never say yes to again.
Right. So I ended up, the next thing that happened was that this lady starts waking up, okay, and starts bucking the
ventilator
vent that she was on, okay? She's like trying to rip out her stuff. And I'm like, this cannot get any worse. So I'm alone. Like, I don't even know how this happened.
I can't get past they left you.
Yeah. And I thought that they were going to go get stuff. Like, that's what I thought until they were gone. Like, no one was there anymore. So I end up calling the doctor that's on her chart, which is a nephrologist. And I'm like, bro, I need sedation orders yesterday. Like, right. He said, I don't do that. I said, you are today. And then I just rattled off like the sedation orders that we would normally use in the ED. I was like, I need this, this, this. And he's like, yes, ma'am. And so he put those in. The other sucky part was I'm in a different unit. My Pyxis code, or like my fingerprint for the drugs.
Yeah, won't work.
So I had to like talk a dialysis nurse to let me get drugs out under her. Oh my gosh. But I called the like the house supervisor. I was like, I don't care who you send me. You got to send me somebody to help. And then the sweet angel from above. We had it was a role called SWAT, which means service without territory.
Yeah.
She came in, bada bing, bada boom. We're going down the hallway to the ICU where they had like a whole team of people waiting for us. But man, did I enjoy it? Absolutely not. But I was so grateful to have had experience in bagging people, sedating people, doing that critical care stuff, because I was left in a situation where that was the only choice. was to act.
I'm traumatized. I'm imagining the scene of you in the dialysis unit and everybody just handling their one-on-one dialysis. Their dialysis patients, the alarms going off, beep, beep.
Yeah,
beep,
sounds like she
like,
needed dialysis with that
Sure
systolic
did.
pressure.
Sure did.
I mean, I don't know anything else about her, but it sounded like she
we
needed
were in the right place for
dialysis.
what she needed, but
Yeah,
we were a little late.
Yeah, a little late for that.
My gosh.
Oh
But
my
was she
gosh.
pregnant, Jen?
You know what? I didn't check. I should have. I need to do
When's
a
your last
final
menstrual period? She'd be like, it's probably what made her stop talking.
Probably. She just stopped up with her period.
Somebody asked me that now these days, I'd be like, what?
No, it reminds me of, back when I was in my training many, many years ago, and I would cover the ICU. And we would the classic consult when you were on your OBGYN, on your ICU GYN rotation, is that you'd get the call to the ICU for the female patient that was having vaginal bleeding, just to discover that she'd been there for 30 some days. And
What do you know?
congratulations, she's got a period.
Right. Surprise.
And you were like,
and the ICU is like, make it stop, please.
Yeah.
Like,
plug it up.
That's
We
not
don't
gonna
do
happen.
this.
Yeah, no, this
We
is
don't do
this
that
is
up
not
here.
this is not convenient. Well, I'm sure she
Yeah.
thinks the same.
Right. Exactly.
Well, what if you had to say, and one last thing before we let you go, but if you had to say, if we all wanted to get better, like ED and OB, what would, I mean, how do we do that? I mean, we talk about it a lot, and we think simulation is the answer to sim together and to work together to get those algorithms in place to where you know which patient goes where and who's going to manage that patient um, and how we work together better for certain scenarios. Let's say you had a patient that was having an eclamptic seizure in the ED. They may or may not feel confident in that management, and then you put the rule situation into there, and it really makes things even more sticky. So, what would be like your one thing that if you could do, you would recommend to kind of bridge the two units?
I think that yes, simulation is super important. But one thing that I've had people come and do, which I think is really, really awesome and smart, is especially for new nurses, being able to come shadow, even if you're going to be an ED nurse,
Hmm.
coming to shadow on labor and delivery for even just one shift, I think can not only increase your comfortability with the normal things that happen in labor, right? If you see somebody coming in screaming that they're in labor, it doesn't mean that anything bad is about to happen,
Hmm.
Yeah.
but also being able to see how, putting on fetal monitors, like what are the kind of things that we look for. I think that that can super help. I've had we have like a residency. It's like a nurse. They call it a nurse residency. When I was back in the day, 14 years ago, whenever I was doing this, it was called the nurse academy. So it was like a year long new nurse training
Yeah.
program.
Mhm.
We would bring in, I say we, they brought in all the different specialties throughout the year and would give us those simulation trainings, would give us like the bare bones minimum stuff that we want you to know if you're ever in a situation where you need to do XYZ.
Hmm.
But it was so impactful and so helpful as a new nurse to be able to not just know resources, but know the bare bones minimum stuff of what you needed to know. So I think that yes, it's important. Yes, for like established experienced nurses to be able to do that also. But I think really capturing that in a new nurse is so critical because it can impact their care over their entire career.
Yeah.
And also having those touch points throughout their career where they can, because if you do it only one time, or you're only getting that uh those in services or whatever just one time, you can obviously forget those things. But whenever I worked in the ER, we would have OB providers and nurses come over and do simulation with us of,
That's great.
yeah, oh, it was fantastic.
That's so crucial.
We would do those for different types of things, like, obviously like PEDS codes or,
Hmm.
stuff like that. But to be able to have someone who's an expert in that field come over and do an in-service on something that they are an expert at was super helpful whenever I was experiencing that on my own. Did I feel awesome and confident? No, but to
You're
have just
exposed
like
to it.
that, like I remember us talking about this, like is a way that you can kind of be more confident in that situation.
I love
Yeah.
that idea. I think
Well,
I think that's not an uncommon thing, but I think it's really, really crucial. That kinda foundational work.
Yeah. And
That's
you
what I'm
don't have
hearing.
I would say to OB providers and nurses, like, you don't have to be invited to be able to do that. I think that it is on us sometimes to be able to reach out and say, "Hey, we would love to do an in-service on," and it could be like a flavor of the month type thing, we, postpartum hemorrhage. We wanna come talk about that
yeah.
with your staff. Sometimes they'll even invite you to like their staff meetings and just
Mhm.
say like, "Hey, this is, in service for this month on whatever." But being able to have that OB-ER relationship, oh my gosh, it's going to improve care for so many patients.
I think that's
Yeah.
crucial.
It
Yeah.
is crucial. I I am so for that, and not many hospitals are doing that yet. They're not quite there, and some of them are getting there, I think. Like I said, but those are the ones that are already working together to determine those algorithms on when to, where the best place is for this type patient. So I appreciate that, and I think the postpartum patient is a huge opportunity to improve care for those patients who may or may not come to your OB-ED or your OB triage, and they may be down in the ED. That's a big opportunity to improve care for those
Sure, for
patients.
sure. Because that's one of those situations where the ER is not thinking pregnancy related at all.
Right.
You come
The
in
baby's
not
out.
pregnant, and so obviously we're thinking just regular stuff.
Yeah.
Um, I don't know how national this is, but they started doing like an I just gave birth
Yeah.
bracelet for
Mhm.
patients. Do you guys do
Mhm.
that also?
I've
If you
seen them, yeah, and A1 has a new, bracelet out, for that, and certain state, quality improvement initiatives have done that. I think Illinois was actually the very first state that did that.
Yeah.
Um,
I just
and
think
of
that's a
course
It's
yeah,
great.
great
yeah, absolutely.
communicator tool for patients who don't even have to say anything. They get picked up by EMS unconscious. I just gave birth bracelet. Oh, okay. That
Yeah.
adds a new layer of perspective on what's going on
Right,
there.
It's
right.
not widely adopted, but we're
Yeah.
seeing it more. It's a conversation that's happening.
Yeah.
Yeah, so
Fortunately.
Yeah.
Yeah.
well, Jen, do you have anything else that you wanna share before we close?
I'm just so honored to talk to you guys. I love having these conversations, and not very often in my current life do I get to talk about my former life of ER, because it is also a love of mine. I consider myself both ER and labor and delivery. So I enjoy talking about it. So I appreciate the opportunity.
Well, I gotta
Uh,
tell you, I didn't even realize it until recently that you had been an ED nurse, so Um, I'm thrilled to talk to you about it, and we do think that there's so many opportunities to improve care for pregnant and postpartum patients in the ED, and to work together better with our ED colleagues. And I do think that, and that one last thing that you mentioned was that those hospitals that are women's hospitals that are standalone, as well as women's hospitals and a children's hospital, huge opportunity to realize that we have to partner with other units, other providers, or you are
Yeah,
the ED,
that's
right?
right. Hmm.
And to expand the practice within those organizations. So, Stephanie, you got anything?
no, I've loved this. We're so grateful that you came to join us. I
Well,
mean, I
thank
wasn't
you.
kidding when I said we're fangirling over here.
Oh,
So we have mad respect for what you do,
thank
and
you.
the way you communicate in such a truthful, authentic way. It just resonates with everybody, and you're just a pleasure. And I know our audience is going to be so happy to hear from you. So thank
I
you.
feel the same about you guys. I think that you guys are such an amazing resource for nurses, providers, midwives, doctors, I just feel like everyone um, is improved whenever they're able to listen to you guys and kind of have some of that more critical care OB stuff.
Thank you. We
Thank
appreciate that.
you. Appreciate it.
Tell us
Yeah.
quickly where you want people to find you and follow you, and we'll put everything in the show notes, including all the info about the book, Birth Vibes. Pre-order it. You'll see her at A1. She'll do a book signing for you. I'm sure you'll have books there for them to buy too. So
Oh, yeah. Well, thank you guys so much. If people are looking for me, any of the regular social media sites, that they just type in Jen Hamilton, they should be able to find me easy. And you can get Birth Vibes anywhere you buy your books.
Awesome.
thanks, Jen.
Thanks.
Thanks, Jen.
Thanks for listening, everybody. You guys know where to find us at clinicalconceptsandob.com. You can find all about our Critical Care OB Academy and our other online education resources at our site. Find us on all the social media platforms, and don't forget to join us at patreon.com/CCOB, where you can help us support our mission and get lots more fun content. So thanks for joining us.